So thank you very much for listening to my talk and taking the time to talk about computational pathology and clinical grade artificial intelligence in pathology. My name is Thomas Fuchs. I'm leading the computational pathology group at Memorial Sloan Kettering, and I'm teaching machine learning at Weill Cornell. Memorial also founded a spin-out called Page AI, which stands for Pathology Artificial Intelligence Guidance Engine. And the purpose of Page is to really go the last mile and build clinical grade tools and softwares pathologists can use in practice after going through regulation in Europe and the US and the rest of the world. So pathology today, I don't have to talk to you how important it is. It's the basis of not only all cancer diagnosis, but of a lot of other diseases. Pathologists have enormous workload. What you see here are the cases at Memorial of a single week. And pathologists still diagnose these cases by looking through a microscope onto glass slides most of the time. And that's, of course, not only a cumbersome process, but also a very subjective process. Then these slides are stored in these vast archives. Memorial has 25 million of these glass slides where it's more or less forgotten. But it's in recent years, the scanning technologies got actually good enough that you can digitize these slides and you end up with these huge images. So here, for example, a skin lesion. If you can zoom in, you see the layers of the skin, other structures, and at the end, you see cell nuclei and stroma and so forth. And you're interested in building software, algorithms, machine learning systems that can detect cancer, find it, grade it, and help pathologists in the diagnosis. So these slides are enormous. All your holiday pictures would fit onto a single of these slides. Unfortunately, pathologists themselves are under enormous stress these days. The number of cases goes up, and with it actually also the complexity of these cases. At the same time, the number of pathologists goes down, and that gap shows that even if we only want to keep the standard of care, pathologists would need to use these kind of decision support systems in the future. And most importantly, that of course impacts patients, and in the worst case, if missed cancers or misdiagnoses are not caught, it has enormous impact on the treatment and the life of these patients. So where are we now? Currently here, we deal usually with rather small toy data sets. You see here the development over time of these data sets from one slide when we wrote the first computational pathology article until these days we have 500 to 1,000 slides. So these are still very small academic toy data sets. And if you build a model on that, regardless how good your accuracy metric is, it's really like training a self-driving car on an empty parking lot. So it will perform perfectly with perfect accuracy, but as soon as you hit reality, it will fail. And reality is messy, it's diverse, it's surprising, and that's what pathologists have to deal with in practice. And the big challenge is here, can you build systems that can deal with reality, that are truly clinically great? So what does it take? It takes, first of all, new machine learning algorithms. I'll show you that. There's no off-the-shelf systems that can be used for pathology in a meaningful way. Second, it takes data at the scale that you can represent reality. Third, expertise in machine learning and pathology. And fourth, very often overlooked, the capacity to build these models at petabyte scale. So Memorial started digitizing over 5 years ago. We have now 1.5 million slides approximately, which is 1.5 petabytes of data. And that allowed us to build models, for example, here in prostate cancer, based on 12,000 slides. And at that scale, the hope is that you can build systems that now represent reality and can be used in the clinic. To do that, we built a supercomputer of GPUs with a lot of enthusiasm, as you can see, which allows us to train high-capacity models, so top-notch AI, also in pathology. One of the biggest bottlenecks is manual annotation, as you see on the left. Most systems rely on clicking on cells or annotating lesions, on which then the algorithm is trained. To overcome that, on the right, we came up with a new approach where we can directly train from pathology reports. So in these cases, you do not know where the cancer is. You only know that there is or there's no cancer on that slide. And it's really a needle in a haystack, like a pathologist who has to look for that needle. For an algorithm, usually it wouldn't be possible to find that. We came up with a system based on multiple instance learning. Here, the slides are tiled in small patches, and then a deep convolutional neural network is trained to detect the cancer. So you can imagine you have two stacks of slides, one of which you know there's no cancer and one of which you know there is cancer. And if the algorithm looks at them over and over and over again, it learns the difference. And the difference is not based on pen markings or IHC color differences. It was really based on the morphology of cancer. So over time, these algorithms learn, and that's with thousands of slides that become near perfect. We showed this in prostate cancer, skin cancer, and breast cancer. But at this point, you still should be skeptical because there's so much hype out there. And even if I show you a good RSC curve on larger data sets, the question is, does it really generalize? To that end, we built a test data set of 12,000 prostate cancer patients from 800 institutions out of 45 countries. And we did not do any data curation. Every slide that was good enough for pathologists was good enough for the algorithm. And the algorithm, the AI, generalizes to these patients as well. So it's truly the morphology that makes the difference. So what is all of that good for? So first of all, the impact on clinical practice could be that pathologists can reduce the number of slides they spend time on, so they could get rid of 75% while focusing on the difficult cases. The second one is, and what you see here is the difference of pathologists' detection performance in finding cancer before and after the washout period. And we could show that pathologists from community hospitals who are under enormous stress miss lesions naturally. And with the use of AI and these decision support systems, they could, on average, increase the accuracy by their sensitivity by 17% without loss in specificity. So it's really a tool that enables pathologists to be as good as pathologists in ivory towers like Mount Sinai or Memorial. And to that end, it's a good example of democratization of knowledge through AI. And lastly, most importantly, if you use these algorithms for quality control, for example, or to detect these lesions, it helps the patients. So it truly generates better care at lower cost. It can also be used on the pharma side to predict molecular alterations and protein expressions. It's faster and can help the patients in predicting treatment response. So to conclude, in medicine, we truly don't have to be afraid of terminators that are in terms of AI and so forth. And especially in healthcare, patients are dying today, not because of AI, but because of the lack of AI. So thank you to the great teams at Memorial and Page who made that work possible, and all the collaborators at Memorial Sloan Kettering and the other institutions. So thank you very much for your time, and I'm looking forward to the questions.